That must be, there we go. Okay, so we're gonna dive right in and get rolling here. So let's talk a little bit about these removable airway expansion appliances. Let's start off with the 2-screw appliance that we use from Ollendorf Appliance Lab.
Yeah, so this is a fun, it's a basic appliance, 2 center screws. Basically, we consider this for any class 1 or class 2 underdeveloped adult. And so the key is maxillary development is what we're looking for. And these appliances work wonders. And the combination that we're looking for is going to be patience, because this is considered a slower process, and compliance. And so we need a nice match in the patient to be able to use this. But generally the appliance is comfortable and simple to use. It doesn't really come with anything that would cause the patient pain. It isn't difficult for them to turn the mechanism. And we're a big fan of this when we need some sort of maxillary development in our class 1 and class 2 patients.
Yeah, and I'm the perfect person to have this right now. So this is my best friend. I'm in the 2-screw appliance, and I don't know, Dr. Miraglia, if you can see, it's pretty wide, right? Aren't you impressed?
Yes, that is several millimeters expanded already.
Yeah, we're getting there. So yeah. I don't know if you can tell by the smile line yet, but slowly but surely, it has really been fairly easy, I have to say, to use coming from aligners full time. There's actually benefits, I find, to the removable appliance, and there's benefits to the aligners as well. But for firsthand, so far, so good.
Yeah, that appliance is very nice, and we offer it to patients who have, basically the maxillary underdevelopment, and we're looking to make a bigger change than just where we can go with clear aligners.
Right. So let's talk a little bit about the 3-screw appliance.
Sure. So the 2-screw is very nice for the class 1 and 2 patient. It covers, that's a large group, but we do have a percentage of people in the class 3 category. And if you're in the class 3 category, whether it's 3%, 5%, 7%, whatever the numbers are, we do meet people who are class 3. They need a little more maxillary development. And so I think less of the class 3 and more of the severe maxillary deficiency kind of a thought process there. So we're looking for more. We think about the 3-screw, because not only are we going to get our lateral expansion here from the single screw in the center, but the other 2 can drive the premaxilla forward. And so with this, appliance being worn, and again, with patience, because this, is considered slower, and with patience and nice compliance, if the patient will follow the instructions, it should be comfortable, it should be simple to use, and over time, it should help to grow the maxilla. And either way we go, 2 or 3 screw, we've got the class 1, 2, or 3 covered. So now we can, offer this to any adult who we could, let's say, diagnose with an underdeveloped maxilla. And these appliances fit nicely between, let's say, a more aggressive approach, which could be in the surgery category, because on one extreme, let's say, we have jaw surgery available. And so the procedures exist, and they do have nice success. I have had patients choose jaw surgery in the past, and it's not as common to choose that given the choices. So when a patient thinks about jaw surgery, you have that whole dynamic versus, let's say, the other end where you could go with clear aligner alone. How much can you accomplish with clear aligners alone? That question we're saving for another evening. We're going to get into that in a separate session.
2 weeks. 2 weeks.
Yeah, so in 2 weeks, we're going to cover that. What can you do with clear aligners alone? Well, this position's in between. So when you're thinking about, jaw surgery techniques versus clear aligner alone, what's the in between? Well, these, a removable, simple removable type growth and development or expansion appliance fit very nicely in between the 2. And so we find these to be a good choice for a lot of adults to help with the maxillary development. And then what happens there is these appliances allow us to transition into the clear aligners. So these appliances aren't really for finishing, they're for foundation. So we think about these as our starting point. We're going to get involved with these so we can grow a maxilla, basically provide us with an opportunity to transition to clear aligners for the tooth finishing component. So it's foundation first, teeth second, and that theme carries really all the way through children, teens, and adults. But in the adult category, these appliances fit nicely between jaw surgeries and clear aligners alone. So you have a technique in the middle that there are patients who are willing to, devote the time to do a nice job with this. And they're wonderful. They do wonderful things.
We had many questions on the chat just about the surgically assisted rapid palatal expansion. I know you don't do those procedures, but can you just touch on a high level where that may fit in this whole
Yeah,
scenario?
and so absolutely. So when I was mentioning surgical techniques, I was thinking more along the lines of MMA. In other words, maxillary mandibular advancement techniques. If we're thinking about full jaw surgeries to reposition the jaw wider and forward, that's going to give your tongue a lot of room. That's going to change the nasal cavity. That's going to open up the tube behind where the air is flowing. In other words, you can make a big airway difference with jaw surgeries that are coming wider and forward. And then if we wanted to look at, surgically assisted rapid palatal expansion, you have MARPI, SARPI kind of procedures where they, give those little initials to them. That would fit between the big jaw surgeries and these. And so from big jaw surgeries to MARPI, SARPI to just removable appliances like this. And so that category, while it exists and there are people who do a lot of that and teach a lot of it, it just hasn't been a technique for me. And so I do not offer my patients the MARPI, SARPI category. And so we do a lot of clear aligners and we do a fair amount of removable expansion appliances where we accept the time frame and the commitment to making them work well versus jumping into implant retained and or fixed expanders with surgical assistance. So those would fall between these and the full MMA procedures. I would encourage people to look into who's teaching that because it's definitely a good tool to have in the toolbox. And I have no objection to any of those techniques. I know I've seen the cases before in some presentations. They do beautiful work with those techniques. I would encourage people to learn more. It's just not something I teach.
Great. So thank you. You answered about 20 of our questions in that one answer.
Yeah,
there's a lot of interest there.
That's a different evening.
So, right. Thank you so much. Okay. So let's talk a little bit about the lower appliance. I know I'm in this appliance because I wanted to compare it, frankly, to the clear aligner experience. But tell us a little bit about when you would use this and the difference between this and, say, clear aligners for the lower expansion.
Yeah. So, it turns out that the clear aligners are very effective at lower uprighting. And so when we're thinking about the lower arch and the anterior crowding, it usually comes with posterior inclination. And that set of posterior teeth that kind of leans on the tongue, they just need simple uprighting. So when you're thinking about posterior simple uprighting, because clear aligners are so effective at that, I end up using clear aligners for most of the lowers that we come across. And there are some adults who come in so crazy narrow that we would consider the lower expansion. And, for that conversation, it goes a little further down the technique and the diagnostic because there are measurements in the transverse. We can talk about transverse measurements where we have a gauge for how narrow someone might be. And if someone comes in really narrow, we start talking about both appliances because we're going to need a little more of, this type of movement prior to going to the clear aligners for the full uprighting. And so in my world, most of the cases where we decide on removable expansion appliances, it's going to be the upper only because the upper only with lower clear aligners can deliver the whole job. And then on rare occurrence, we go with both the upper and the lower expander to drive more width before switching into the clear aligners for the final, alignment of the teeth. So I use this less often, the lower one, but it's very effective.
Could there be an economic advantage by using the upper and lower expanders than just finishing with the aligners?
Yeah, if you think about having the upper expander only, you'd have a lab cost, for that upper expander. Now, if you add the lower expander, you have that lab cost. And then clear aligners are coming with a lab cost. So probably the largest, let's say, lab cost would come from both appliances and then the clear aligners are coming. So if I could cut out the lower removable expander, I could save that lab cost there. So it might be, I've never made that decision based on the economics, but the reality is when you're ordering, removable expansion appliances from, in our example, Ohlendorf Appliance Laboratory makes these for me. If I order an upper, there's a lab bill, but if I order a lower with it, then there's the lab bill's more. So you're getting two appliances. I've never ordered it based on finances. I tend not to think, about it in that way. It's usually about, will the clear aligner alone deliver the full lower movement for me? And if I feel like it's just too narrow and I could save time, because with this appliance, it might take the lower out there a little quicker than a clear aligner would. But we're not talking about a major time change. We're talking about a smaller increment of time difference. So the idea becomes, well, if the patient has to wear the upper removable expander, while it's comfortable, there's a level of inconvenience when we're talking about somewhere between 9 and 15 months of use. If you have to wear both, well, maybe that level of inconvenience is a little bit more. And we're talking about this up front so the patient knows what they're committed to. If I can solve the lower with clear aligners, it's one level less inconvenient, so to speak, when you have one removable expander to deal with. And the patients who have two have a little more going on. Again, it's for a time frame. This isn't the rest of their life. What they do solve in this time frame is a lot of the symptoms that they can now enjoy being free of for the rest of their life. So we'll talk about that when we see some patients coming soon.
Absolutely. So let's get to the patients. This is really, it's hard to show without showing you some cases to actually show and tell. So tell us a little bit about this case.
Yeah, so we meet our patient here, and this gentleman came in, and of course, when you're in your 40s, you're still a young guy and you have a long way to go. And so we would look at this mouth and recognize that, a gentleman like this is going to have a chief complaint. And so certainly, usually the patient's chief complaints will land in two categories. The first is the aesthetics, and the second is going to be the discomfort. So patients who have discomfort will tell us about toothaches, TMD issues. They'll tell us about sensitivities. They'll tell us about biting a cheek or biting a tongue or things that are uncomfortable. So when you get pain or discomfort, you're going to hear it from the patient along those lines. Anything from the teeth, the gum, the jaw joint, or biting a lip or a cheek. You get those descriptions. As far as the aesthetics go, the patients are focused on their aesthetics. They look at their front teeth. Well, they're not lined up, they're crooked, or I had braces, I didn't wear my retainer, they're crowded again, or I never had the opportunity for braces. So you're going to get one of those two pathways. So patients will talk about the look and the level of comfort or discomfort they may have. There are your two categories. Meanwhile, when we meet, someone like this, we're recognizing that, well, if we've got an upper arch that's in a full posterior crossbite like this, well, the consideration really is the tongue. When we're talking about giving, more room in the oral cavity, it's nice to have a good occlusion. Our goal is always to have the teeth come together in a protective bite, that can destroy the food, but not itself. The idea is to have more tongue room. And so having listened to Dr. Gerald Simmons for quite a bit and having a chance to talk to him, and he happens to be a nice clinician and researcher that is triple board certified in neurology, sleep medicine, and epilepsy. One of the things I'll never forget that he told me was that when you're thinking about the nose and the tongue, as far as your breathing issues go, the tongue is 90% responsible for the trouble. And so the idea behind what we're looking at is, yeah, everybody recognizes this is a malocclusion, and we could label it all kinds of things. But the biggest issue here is really, how much room does the tongue have? And in that consideration, well, where's the tongue supposed to be living? Well, the tongue belongs in the palate. And so the tongue's home is really the upper. So if we're thinking about the upper, it's smaller than the lower, which is bad news because this is upside down. The mouth is supposed to be like a shoebox where the lid goes over. So the top and maxilla should be the shoebox over the lower. Meanwhile, this patient has no room for their tongue. So they're bound to come with narrow comes with vaulted, and narrow and vaulted comes with a compromised nasal chamber. So it'll be no surprise when we start asking this patient, have you ever thought about visiting an ENT for a nasal scope to check out, what's, well, I've already had that. I had a nasal scope because my breathing, my snoring, and you start getting the history. And I know I have a deviated septum, but I didn't want to do the surgery. I didn't fix it. So now that's on the list. Of course, if we're thinking about a Dr. Simmons and what he may think about nose and mouth, well, if the tongue is 90% of the problem, well, that's our world. We can help out this gentleman with, one of the options being removable expansion appliance. And we can start giving the tongue more room while we're headed towards a more appealing smile and a more comfortable bite. Meanwhile, what we're doing is we're helping the tongue have some more space. Then, of course, okay, well, what's left if there's a deviated septum that will interfere with airflow through the nose? The patient always has that as an option to pursue. We can only educate, we can't force. He already has had that scope. He knows he has a deviated septum and he hasn't pursued it yet. So look, our goal would be if we could win him over and treat this to a point where he recognizes this was a significant difference in my life, maybe I then pursue the ENT one more time. We might bring it up in the future, but this is something that's going to come with narrow and vaulted, and we know we're going to have compromised nasal cavity as well. So we enter into a conversation, look, John, there are jaw surgeries that are available to you. We can talk about different types of jaw surgeries. We can have oral surgical consultations. We can do the workup. It's so beautiful today with digital, consultations. They can really show a nice thing to a patient. Doesn't mean they'll agree to it, but it's nice to do, informed consent. From jaw surgery, we look at our next option, and in our world, we talk about removable expanders for adults, and so we would teach them all about that. And if removable expansion for the upper arch is something that we can, perform and do over the course of anywhere from 9 to 15 months, we would be transitioning to clear aligners. Now, if the removable expansion appliance isn't appealing to the patient, we move to step 3. Step 3 is going to be, let's get involved with clear aligners. And there will be some limitations because this is, full posterior crossbite is a wrestling match with clear aligners. And, clear aligners alone are going to struggle with this. We would have to get involved with auxiliaries and other stuff. I'm not a fan of attempting this case with clear aligners alone. So while I love clear aligners, this would not be the case I would enjoy doing. So my goal is to get in and out of that consultation with the patient agreeing to a removable expansion appliance. And I think we have a nice photograph coming up that would show.
Yeah, let's take a look and see.
He did a wonderful job with it. So so here we have, here is his upper arch, and of course, it's narrow and vaulted, and narrow and vaulted go together. If the upper arch is narrow, it will be vaulted. We don't get the opportunity to be very narrow with shallow. That doesn't exist. We're not made that way. If the side is coming in, then the vault is popping up, and so we get this narrow and vaulted effect. We're either wide and shallow or narrow and vaulted. Now, the more narrow, the more vaulted, the more compromise into the nasal chamber, and of course, these are patients that more than likely when they get to an ENT, they're going to be talking about the nasal scope and the discovery that there's a deviated septum involved. It just kind of goes with the domino effect of narrow comes with vaulted, comes with deviated septum on some level. So you get that diagnosis from your ENT. Tooth number 8 has already had a root canal in there. So you can see the little access chamber is going to have to be filled with composite. So we got a little traumatic occlusion on the edge to edge. He's narrow. Hasn't had a ton of dentistry in his past, but when you get a root canal on number 8 out of nowhere, all of a sudden, well, you got a traumatic occlusion and maybe we should think about correcting this because here we are at 45 or mid 40s, there's another 50 years to go. And so if you're thinking about 90 to 95, that's a long way to go for this bite to survive. And we've got some recession and we've got, either sensitivity or issue. Here's a patient who their mouth's going to deteriorate ahead of schedule. On top of it, the tongue has no place to park. So you already have a patient who's got the mouth breathing, snoring, sleep disorder breathing, and deviated septum in there. So you have a list of things going on. This is not a healthy patient. So you have an opportunity to make a difference.
Absolutely. And hygienists can be an important part of this conversation as well, for sure, because when we see patients like this, we can start these conversations. So it's not all of a sudden a shock when the doctor comes in they start talking about all of these signs where the hygienist just spent, 45 minutes and then the doctor comes in and spends 2 to 10 minutes, whatever.
Yeah, that's the best pathway to education is through the hygiene. They have more opportunity. They have more time, they have more opportunity, and usually they have the better relationship with the patient anyway. So at that point, you have a hygienist absolutely able to start to talk about these things. And even if it's in the conversational mode, you're learning about the history and what the patient has going on. That's really nice stuff to be gathering, that they're snoring and all this stuff going on. Next thing you know, you've got a pretty good list and it adds up to being 45 years old, but not so healthy. And here come these little check marks, but most of it's recognized here where the tongue just has no room to live in that chamber.
And frankly, if I worked in the office that didn't provide some type of expansion, I wouldn't know what to tell this patient to do, except, go see Dr. Miraglia, which I couldn't do.
Well, the options are limited. If we can't get involved with surgical and we can't get involved with surgically assisted fixed expanders, which that category exists, we covered it. I don't really, do that technique. And we can't get involved with removable, then your options start running low because this isn't exactly a really nice braces case or a liner case. It's more foundational than tooth. And so when you have more foundational, clear aligner alone is going to give you limitations, and braces alone aren't really for foundational changes. So those two don't offer the patient the bigger change. So we're interested in getting this patient educated to accept a removable appliance and kind of come with, deal with the patience and, time frame that it comes with, because it'll make a nice change if he could do it.
Well, you got him on board, so you
Yeah,
did a
he
great
did it all
job
right.
with patient education. So
Yeah,
tell
he
us a
did
little
it.
bit about this progress.
Well, we're dealing with someone who's in their 40s and mid 40s, is an age where you're considering you have mature bone, but you have the opportunity to, grow and change this. And so what we're looking at is his, removable appliance over 6 months' time, gaining, a significant number of millimeters in width. And so that opens up, the entire dentoalveolar complex here. You're going to have sutural change. You're going to have a really nice opportunity, provided, the two things happen. Number one, you need your patient to be very compliant, and they need to follow your instructions. And so, if your patient will wear it nicely, that's great. If they'll listen to your instructions, then you can have this type of change. It's more common when people, try these appliances. If they don't have enough knowledge, next thing you know, while it's a simple appliance, it does need to have a nice clean technique to get this type of change. This appliance, it's probably easier to misuse it with just a little bit of a lack of the knowledge how this would work. And so to go from one side of the screen to the other is a big change, and we'll see it in a moment without the expanders in place. But you're looking for, bony change, not just, tooth change. And so the idea there is you need the right patient, which is why we have a good conversation to educate the patient. And you need them to not only be compliant throughout the process, but to follow your instructions nicely so that we can achieve this difference. And that's a significant difference. This is probably the first 6 millimeters of expansion here. And we're usually looking for minimum 6, 8, 10, whatever you can get. If the appliance gets exhausted, we order a second one if we feel like we want more. And sometimes that depends on the patient's symptoms, because you get to a point where if the symptoms are fading away, maybe after one round, you can go right to your clear aligner technique, which is what happened here. He needed a single round. When we got to a point like this, we ended up switching him into clear aligners, foundation first, teeth second.
So let's see how he looks.
Yeah, so here's our image with, it's exactly the same time frame, just without the expanders in place. So the before and the expansion appliance. And, with the removable expander alone, not only do we get really nice arch development, but we get a change in the vault. And we also get an amount of alignment, because as that arch is growing nicely, the teeth can start to kind of take a little bit of shape. And so this is the point where the only thing he's really had is our removable expander and a little bit of myofunctional therapy, because any little bit of, and I know orofacial myofunctional therapy, it's a mouthful of words, but it really can be helpful for patients. And so when we talk about the appliances, more often than not, we're also including a level of myofunctional therapy. And there are some patients who do those exercises beautifully, and then there are those who don't. In my world, I refer a lot of these patients out, and I send patients to a myofunctional therapist. I have the opportunity, because they're within 30 minutes of my office, I can make a referral. So in my office, we do a little bit of myofunctional therapy. We refer the patients mostly. So a gentleman like this does a little bit of myofunctional therapy. He didn't do a lot of myofunctional therapy. But the idea here is, if you start to give the tongue more room and it takes it, and you end up with symptom reduction, you're heading in the right direction. And usually when you're giving the tongue more room, good things are going to happen. And so you're not done until you give the tongue the right amount of room. And in his case, he's going to have a percentage of the issue coming from that deviated septum. Even though this is going to alter the palate and make a difference in the tongue space, this technique alone isn't going to remodel his septum fully. So if we sent him to the ENT at this point, or at 9 months or 12 months, they're going to come back and tell us he still has, a deviated septum in there. It's not going to spring back to straight. This is a gentleman who did not correct the septum. We have patients who go, in one of those two directions, either before, during, or after treatment. They'll agree to have their septum corrected. Those patients notice a bigger difference in the outcome, because now, like other patients who get a deviated septum corrected, it's a common outcome for them to say, I didn't know I was breathing that badly, but after having it fixed, I know how the air is going through. My nose is, the air is flowing through my nose so differently. It feels like I'm getting, a burst of air through my nose when I breathe. So the people who correct their deviated septum speak freely about how much better the air flows through their nose, but not everybody does it. He's one of the categories here. This gentleman did not, and he still hasn't. And this is, going back 5 years ago, we treated him, and here we are. We still don't have we still don't have his septum corrected, and I don't know that he'll ever go do it. But meanwhile, this is the removable expansion alone delivering this change. And at that point, it's appropriate to switch him into clear aligners, because we can take the clear aligners and continue the process. Now, the key with transitioning out of the removable expansion to the clear aligners is that you still want your technique to be wider and, driving with opening up the arch more. And so we don't switch gears when we go from the removable expansion appliance, even though that's focuses on the foundation and it delivers beautiful tongue space. We don't switch to aligners to then tuck the teeth back in, or to, let's say, close a space that open. What we're really looking for is to continue uprighting and opening up the chamber as much as possible. We'd like to make the biggest parking garage possible for the tongue. If the tongue has a lot of room, again, good things happen. If the tongue has a small space, bad things happen. So the clear aligner technique following your removable expansion appliance is given. In other words, I don't have any adult patient that goes from a removable expander to being finished. There's no such thing as that leaving you with a well-aligned and well-coordinated occlusion. That's a foundation appliance. And so any adult that's beginning with a removable upper expander or a set of removable expanders is getting clear aligners, because it's foundation first, teeth second. So they know up front, you're going to have an amount of time in this expansion appliance. You're going to have an amount of time in clear aligners. This is what we're in for, but this is the difference we get to enjoy. And so here's a gentleman who, if he has that much difference for the room, for his tongue to be in, all of a sudden he's going to talk to you about how much better he's sleeping and breathing. Now, someone with a deviated septum and who has that narrow chamber to begin with, we put them all into a nasal hygiene, protocol kind of thing, because even if you have a compromise in the nasal chamber, it doesn't mean you can't do little things to make a difference. So all of these adults are told, the new bedtime routine is going to be blow your nose, spray your nose. A couple minutes later, it'll loosen up, blow it again, and put on a breathe right strip. Now, breathe right strip works on the outside. It'll hold the nostrils open. You can use inserts too. But the idea is you just want to improve or increase the airflow through the nostrils and through the nasal cavity. So patients like this will get those instructions. Let's get the air flowing through your nose better. If we can get the air flowing into your nose better, if we can give your tongue more room, maybe all of a sudden you see a difference in how you're sleeping and breathing. And again, this much change in the arch, form and size is going to make a difference. We don't have patients who achieve this kind of change and then say, I feel the same, I'm still the same. Because thanks to Dr. Simmons clarifying for me years ago, he made it clear the tongue space was 90% of the problem and the nose is 10%. So when my patients don't correct the nose, I'm still okay, because the change that we can make in the oral cavity is going to, be a significant difference for them that they would know and tell you I'm improving. So we love working in the oral cavity and giving the tongue more space.
Well, that's good news to hear for us as oral physicians, so to speak, right?
Yeah,
I have
the
a
dental community.
question.
Yeah.
I have a question that I think would be great to answer at this point with these slides up, because I get this often. Is it mostly dental tipping rather than skeletal expansion? So maybe you can touch upon that using these slides.
Yeah, the difference between getting tipping of teeth versus bony growth is going to be the technique and the wear time. And so, we spend a whole day teaching this. And so it takes a little while to go through the technique, because it's very easy to misuse the product. In other words, if you just take that appliance and you're turning it wrong, or the patient's wearing it incorrectly, you're going to tip the teeth. It'll be a tooth tipping appliance. And so it has to be used in a manner that's going to give you, bone growth versus tooth tipping. So it's a very good tooth tipper if you're using it incorrectly. Okay. And so I hear that a lot, and I see that, a fair amount for patients who attempt these and then they kind of abandon them. So if you could learn a nice technique and have a patient who's cooperative and following your instructions, this is the kind of outcome that you'll get. And we're going to showcase a second case in a moment where you could recognize that you're getting a foundational change so that you can then align the teeth with the clear aligner. So the goal is not to have tooth tipping, but if you were to see that, it just means, you've got two things going on. It's not being worn correctly, it's not being adjusted or turned correctly. And now you have, poor technique is really how you get the tipping of the teeth versus the bone growth. And those removable appliances come with a commitment. If it's not the right patient for it, sometimes we don't get through 6 or 9 or 12 or 15 months of those. So I've had a patient or two after 3 to 4 months, they recognize that it's intrusive in either their social life, home life, or work life. And if a patient reaches the point where they recognize, I can't wear it correctly, I can't do the right time, I can't do the steps correctly, then it more often than not becomes an appliance that's misfitting. And misfitting leads to, well, you're going to have your tooth tipping issue. So you can kind of pull the plug rather than watch the teeth just tip out of place and make a mess. So the good news here is it's such a slow process. Nothing can get out of control because this is such a slow process that as the months go by and you're checking your patient accordingly, you would know right away that the fit as well as the look in the teeth, is it going through the bone or is it going through the teeth? And how are we doing? Because we can get back on track and do it nicely, or we should discontinue. And yet that happens occasionally. So it's all about using it correctly.
Okay, terrific. Let's take a look at this case. Tell us a little bit about this young lady.
Yeah, so we meet this young lady at 19 years old, and she has every bit of a malocclusion we could recognize underdevelopment. And so having the maxillary underdevelopment has produced a bit of a crossbite in the teeth, but we have crowding, we have a history. So this patient gets referred to us nicely by Dr. Michael Gelb. I have a wonderful opportunity to collaborate with him on a lot of cases. Dr. Michael Gelb tends to meet the patients before I do. A case like this would show up with TMD symptoms, including headaches. And if this nice young girl meets him, he can provide a level of relief. And so Dr. Gelb works a lot with sleep appliances, with TMD appliances, and auxiliaries throughout to care for his patients, and has made a big difference in a lot of lives. And I know Michael well, and one of the benefits of collaborating with him is that he can make a referral to add to the patient's cooperative care and collaborative care. And so this is a patient, the short story is going to be that she has, as a teenager, she has a history in braces. Prior to braces, she has no history of TMD and or headaches. Into the braces, as the braces are started, she starts to develop, headaches and TMD. And then, about a year into it, has a significant weekly headache episode. And then, by the 3-year mark, the braces come off. And, that was probably around age 15. So by the time she's 15, she's well into TMD/headache symptoms and struggling with those, because when they're weekly or more, it's going to affect your quality of life. And then meanwhile, these are the photos of the occlusion after, a 3-year run with some braces. But when Dr. Gelb meets the patient, of course, through his protocol, he's going to get this patient, more comfortable. And so if a patient like this comes in with disc displacement and or significant, muscle and joint issues, he can reduce that level a ton. But, with his techniques, the limit is, well, he's not moving the teeth and he's certainly not doing, jaw growth and development there. So he says, hey, why don't you go see Dr. Miraglia? Let's see what he can do with your, orthodontics, so to speak, because your bite's not good. So the patient gets to a level of comfort, we meet her. And so when we meet her, this is the kind of bite we're looking at, and we know it's not a tooth issue. This is the foundational issue. So we get the opportunity to treat her. And at 19, we consider that an adult. Now, yep, she's still very young, but 19 is not 11 or 12. And so at 19, we take a look and we've got narrow, vaulted, and this patient has, we can look at number 7 as being an undersized lateral, and 10 is like a little peg lateral, we might call it. So we got these 2 tiny little teeth. The other teeth are beautifully developed as far as proportions. It's a really nice, healthy set of teeth, so to speak, but we need foundational change and then tooth movement to do it. And, we know that she has an unsuccessful history with brackets and wires not working for her. But now we have a patient coming in with significant history, and we get her involved with the upper removable expansion appliance. This is the first 5 millimeters. And so, with the first 5 millimeters, we start getting the separation between teeth 8 and 9. And if you notice, at the top of the screen, 8 and 9 are separated by a couple of millimeters, and yet there's nothing pulling or separating those two. There's no other wire or arm on this. And so this appliance is driving sutural change right down the center. That's why you see 8 and 9 separate. So it's very common at a certain stage to recognize that the two teeth 8 and 9 are separating. And that's a really nice indication that you've got mid-palatal sutural change when 8 and 9 are separating without anything pulling them apart. So without any brackets or wires, just with a really nice technique and a very compliant patient, all of a sudden we get the first 5 millimeters. And this patient, we took all the way to 7 millimeters with this removable device. And I think we have a photo that shows her getting out to, yeah, there we go. So I had measured the transverse measurement. I like to measure between 3 and 14 and have that as a baseline. And so between teeth 3 and 14 at the beginning of this case, there's 27 millimeters there. But when we go from that beginning of 27, her removable expander alone delivers the first 7 millimeters. We're up to 34. So we get to a 34 millimeter change here. And I mentioned in the first case a little bit of myofunctional therapy. Well, in this case, one step farther in that, she actually had a tongue tie. And so I like to talk about Dr. Irene Marquezon doing, her protocol for, objective tongue tie assessment. And so when we think about a score of 0 to 8, this is a patient that would score like a 5 in Marquezon's protocol. And with Dr. Marquezon's protocol, you have an objective way to say, we've got a tongue tie. So this patient, along with the removable expansion appliance, did myofunctional therapy prior to the revision for the tongue. And then, of course, when we look at this result, having 7 millimeters of change, we would think about these things that were involved, because the removable expansion appliance does a wonderful job, but I can't give it all the credit because we add a little nasal hygiene. So the patient's going to start to blow her nose, spray her nose, blow her nose. We might use breathe right strips. Anything we can do to improve the airflow, through the nose. If we can keep the mouth closer in better shape, because then the tongue starts to go into its home, the palate. But we also referred her to a little myofunctional therapy with the Frenum revision, and she did it. So she went, the parent and her went, they got the revision done, they did the therapy. So now we've got a tongue that can go to the palate because it's not restricted. So when you think about the list of things, the removable expansion appliance is wonderful, and I can give it most of the credit, but not all of the credit, because when you think about nasal hygiene and you think about myofunctional therapy along with the tongue revision, all of a sudden Frenum revision with therapy and boosting that tongue into the palate, that not only helps the maxilla to reshape, and you can see there's a big difference here between the upper vault on the left side of the screen being very high up, like someone pressed their thumb up there, to how that vault is remodeling. And now on the right side of the screen, the palate looks like an imprint of the tongue all of a sudden. So now you have the right shape and size. If you develop the right shape and size, good things are going to happen. And so here we are opening, this patient's, maxillary arch. And with all of that development comes the alleviation of the symptoms. Now, in her case, the symptoms began fading within weeks. But by the time we got to this point where we had removable expander only, and we had our 7 millimeters, she was headache-free, TMD-free, and no muscle issues. Here we have, at this point, an asymptomatic patient, but it's time to head into the clear aligners to finish the alignment of the bite and have a beautiful occlusion when we're done. Restoratively, of course, we'll address 7 and 10, because if we're going to open this all up, I have the advantage of those two little teeth to leave the space there. If 7 is too small, proportionally, let's add to it a little bit of bonding to see where things land. And 10, I can get the bonding on 10 like anybody else and make it look bigger until such a time that ceramics are indicated. And I believe we have a photo to show where we finished. So we're going to leapfrog from the expander to finished. Now there's a big difference. A big difference. Now the patients who wear clear aligners use a lot of whitening gel, and they get addicted to it fast. And so this is whitening gel on all the other teeth, but 7 and 10 are composite. So when we're looking at this mouth, the restorative dentistry is on 7 and 10. So I put bonding. It's bonding on 7 and 10. Everybody should be aware. Every other tooth, it's only whitening gel was used in the clear aligners. But the big difference is a foundational change. So the patient has a fully developed maxillary arch, an upright position of the lower teeth. They come together free of symptoms. Now, what's more about this is we're 5 years post-treatment. And so we have a patient 5 years TMD free and headache free. And so she has not taken a Tylenol, Advil, or any other medication for a headache in the last 5 years. So she no longer gets headaches. She no longer has any pain or discomfort. And she has a very comfortable bite that she can use for anything. After clear aligners are finished, we do make a clear retainer. And so the patient does, the ongoing retention is going to be clear retainers, an upper and a lower. You wear them every night. And basically, that's going to protect the tooth alignment that we delivered in the end. So the removable expansion appliance delivers beautiful bony development. You get your foundation. After your foundation, then you're obligated to complete the tooth positioning for your beautiful occlusion. And so you get a foundation with the teeth, you put it all together, and then you address the other little items that pop up. And in her case, Frenum revision with myofunctional therapy. And that, believe it or not, is more common than not. And the more you recognize the Dr. Marqueson's protocol and address Frenum as a diagnostic tool, then you can develop it, into your protocols, because you have plenty of research out there that shows that, a restricted tongue, if you have a lingual Frenum restriction of some sort, it'll affect the oral facial growth and development. And in this case, where you have on the left side of the screen, someone who had, an unsuccessful braces round, there's a fair chance that the tongue was restricted, because you can see how the upper arch just never really went out to place. And so we find that's fairly common when the patients come in and we have a history of years in braces, but didn't really get the job done. Something might be missing. And one of the items that's very common is tongue tie. If the tongue is restricted, well, now you have no support for anything you're trying to do. And more often than not, it's going to be unsuccessful and want to relapse quickly, because the tongue wasn't given a chamber, nor is it free to get in it. So no matter how much you try to get it where it goes, you can probably get the braces to make alignment. But if you've got a significant tie, you may come up short. And next thing you know, we've got a patient sitting here who tried, and that just was unsuccessful. So foundation first, teeth second. And you got a happy kid here who, to this day, I still haven't done the ceramics there. This is going to be a 24, 25-year-old coming up soon. And I didn't get to do the two, ceramic restorations, because I shouldn't have done the bonding so nicely, I guess. Maybe a little darker shade.
It's a beautiful case.
Yeah, I should have went with the A4 in the composite, and then said, oh yeah, because of the whitening gel, you can only get the whitening in the porcelain. I missed my opportunity to get the veneers. But anyway.
I have a question that's a good time to answer in this segment here. Is there a method? Yeah. Is there a method to determine how much time will be necessary for patient to wear expansion appliance prior to transitioning to aligners?
Yeah, generally we're looking for 9 months minimum and maybe 15 months maximum. And it's a big range, because I don't really know how the patient's going to do for the first 3 to 6 months. And so we just talk about it, because in a consultation, when you're talking about the patient, there's no harm in saying 9 to 15 months, because I can say at a minimum, I would like to have 9 months, but really it depends how well you can wear it and use it. And when you start talking about when you want them to wear it, how often you want them to wear it, and your technique and what you're going to do on top of that. And if there is a frenum to be addressed with myofunctional therapy, the idea is, you might need the first 3 months to figure out, is the patient going to be able to deliver everything to do this in 9 months, versus will it take 12 or 15, or is it not doable? In other words, if they can't perform all of the steps that you want them to do at the right timing, maybe you are just going to be tipping the teeth, which means you discontinue treatment, because no one would want to continue tipping out the teeth. But now we're just misusing the appliance. We would discontinue and switch over to clear aligners, and we would pick up where we left off and do the best we can. So I would begin with a 9 to 15 month range. We talk to the patient openly. No one's trying to trick them into getting this appliance. I tell them it's not easy to speak with it in place. If you have a lot of talking to do during the day, you're going to trip on it a little bit. You're going to want to take it out to speak. It takes a lot to adjust to it. It's not painful. It's not going to hurt you at all, but it's going to interfere with your social life a little bit. It's going to interfere with your work if you're doing a lot of talking, and it takes a pretty good commitment to wear it. It's not the kind of appliance that if we were going to do it well 4 or 5 days a week, we're going to make it happen. It really is an every single day commitment to get through all of these months to do a wonderful job. And when you go away for a 2 or 3 day weekend and you forget it at home, it's bound to be a disaster, because it's going to shift enough that it doesn't fit perfectly. And you could get off track pretty easily, but it comes down to the patient. You're looking at 2 nice examples where, the patient wore it beautifully and we get a significant difference. I have patients in every category. I have those who do it well like this, tends to be most of them, but we do have patients at 3 months, 5 months, 6 months who reach their limit and they say, look, I'm doing the best I can, but I don't think I can go any more. Well, we got what we got. We made an improvement. Now let's switch over to the clear aligners. it's still better than attempting these cases with clear aligners alone. So we're happy to get whatever we can.
Okay, so we're going to do some rapid fire Q&A.
All right.
Ready? This is a wonderful case. So let's
Yes, no,
go
yes,
ahead.
no, yes, yes, yes.
Yes, yes, yes. Here we go. Can your adult expansion treatment be combined with the CPAP?
Oh, yes, of course. Yeah, when adults that start to respond to the questions you're asking, oftentimes you're saying, hey, it's time to get a sleep study if you haven't had one recently or yet. So adults should get a sleep study when you're talking to them and you're learning about them. And some of them have one already. If it's recent, great. If it's not, go get another one. Because if you're in the OSA category, you're supposed to have a CPAP on. And so the adults wear their CPAP. This is inside, the CPAP is outside. So they're supposed to use their CPAP through all of this treatment. Absolutely. And then the idea is, if you're using your CPAP all the way through and we deliver all of these results and you do each of the things we need, you can get your sleep study again and figure it out. Because if you can get out of your OSA and leave your CPAP behind, well, that's a really big win. But what if you did need the septum corrected to get out of your CPAP? Maybe they would consider it. What if you do need a frenum revision to allow your tongue to actually go into the chamber you're making? It's one thing to build the garage, but you got to pull the car into it. And so, we have to have that adult understand the frenum can be an issue. And so if you're willing to go through all the steps, you wear your CPAP through treatment and maybe you lose it at the end, but that's not guaranteed until you've gone through every one of the steps and checked every box.
Who would you count as an adult? Anyone over 18 years?
Yeah, so that last patient was 19. And so I have used fixed expanders all the way to 17. And, as the years go by, you keep kind of testing to see, what can you do with fixed, non-surgical intervention, of course. But at 19, I didn't feel like testing the fixed expanders there. Whereas by 16, 17, we've still had really good success with fixed expanders and a nice technique. So I'm going to tell you, 17, 18, call it an adult and get into removable expansion appliances. Unless, of course, you have an incredible amount of training and experience using fixed expanders past the age of 12, you probably shouldn't be involved in that. Just because you can make one doesn't mean you're ready to put it in a patient. Maybe you just need a few steps in place to be able to do that. It work well, but try to learn it first.
Other than more tongue room, what are the other benefits of expansion? A patient asks if their face will change and how will that happen with expansion?
Yes. So this is a kind of a short and powerful meeting to talk about intraoral, but both of the patients shown have significant, differences in their smile and their facial changes. And so we see it in the smile and profile because you're going to have produced, a maxillary size that produces a full smile. All of a sudden you go from having a before picture that would look like a very narrow smile line with open buccal corridors to a mouthful of teeth. And when you have a beautiful mouthful of teeth in a full smile, it's going to look different. For the patients who use the 3-screw appliance and you make a change, forward as well, you're going to see it in the profile. And so when we have a bigger, forum and more time, we end up showing more photographs of the faces and the profiles because it does make a difference, but it's always an improvement. No one's upset about their smile getting more broad and showing more teeth. And no one gets upset when their class 3 lip positioning starts to change to class 1 lip positioning. So you have patients who are happy about the facial changes. That would never be a negative. In other words, right. We don't think about that as a negative. It can only be an improvement.
Okay, can I safely use an expansion appliance if I have already had braces twice and have gum recession and flared teeth?
You can, because the expansion appliance is built for foundational change. So it's doing the least to the teeth. But given your history of recession and root resorption, it sounds like you have to make sure that you're using that removable expander correctly, because you don't need it pushing on the teeth only and doing tooth movement. Because if you're going to use your removable expander inappropriately by the wear time or the technique, next thing you know, you do have an opportunity to tip the teeth out. Now, the only benefit is that you're doing a slow technique, so you would know it right away. You can discontinue treatment and go to clear aligners. You're never going to cause something so bad because you wouldn't let it go on for 6 or 8 months of poor technique. You would recognize it right away and say, well, since I'm not wearing it appropriately, I probably shouldn't continue on this path. It's only going to produce an outcome I'm not happy with. But if you're wearing it well, you're getting your foundational change. It's removable expansion device followed by clear aligners. and then it's okay to have it. The thing that you can't have again, or I wouldn't want you to have again, is another set of braces. Because it's if you've had 2 sets of braces and you've got these issues, maybe that's a little too much force, and maybe the recession in the root, it's enough. I don't think I would attempt, braces again. Stick with removable and stick with clear aligner, and at least you're in a category that's safe. You can't really harm yourself any further.
How do implants influence treatment?
Yeah, so in the perfect world, you don't have any in there, but if you have an isolated 1 or 2 here and there, if you're wearing your appliance well, you're getting bony change, and when you're getting your bone growth and development, the implant's not an obstacle. If you're wearing it poorly and the technique isn't appropriate, next thing you know, it becomes, force on the teeth and force on your implant, and you don't get the same results. So you get no result, basically. If you're going to have multiple implants, the more you have, the less predictable your work's going to be. And of course, anything that spans across the front to the other side, if you've got an anterior bridge, you got trouble. Because like we saw, if 8 and 9, if the goal is to have 8 and 9 separate, meaning prove sutural change in the center, then you wouldn't be using this on someone with a bridge across the front, or even 2 implants across the front and it locked together, there. So there are limitations to, how you would choose your cases.
Okay, and would this be considered snoring therapy or OSA therapy?
Not in my office. So I don't treat OSA. I don't treat sleep disorder breathing. I treat underdevelopment. And so I don't treat the list of things like OSA. I don't treat sleep disorder breathing. I don't treat TMD. What I treat is underdevelopment. So what I'm able to diagnose, thanks to the records I'm collecting, I'm able to diagnose underdevelopment. So if I can diagnose underdevelopment, then treat underdevelopment, there's a pretty good chance I'm going to have an impact on the symptoms that are associated with underdevelopment. And so when you have underdeveloped jaws, you have the opportunity for those things. Those are symptoms: OSA, sleep disorder breathing, TMD, recession, abfraction. All these things come from malocclusions of the underdeveloped jaw variety. So treating underdevelopment is where I land. So I don't treat the OSA, I treat the underdevelopment.
Great. Is this a safe expansion appliance for an adult with recession, bone loss due to occlusal trauma, non-active perio, and thin buccal plate?
Yeah, and again, it would be about the technique. If you have a nice technique and the patient's compliant and does the things you want, you get your bony change. So you're going to get foundational change. You shouldn't have problems in the buccal cord or getting worse. And so if you do, then we've got a technique issue, and we've got exerting just pressure on teeth. And next thing you know, we have an issue with how the appliance is being used. It can be a good tooth tipper if we're using it poorly, but patients who have recession and abfraction areas and shorter roots, we're not looking for tooth tipping there necessarily. Right. So we would want to be using it appropriately. Again, it comes with a conversation with the patient. Not every patient is a match for this. And so if you're sitting in a consultation and the patient has to speak for 8 hours, all day, and this is going to trip them up, well, it's not an option for that patient. Maybe that's a better surgical case. And so we would look at a different pathway. But yeah, using it correctly, having recession, having the symptoms or the results of a malocclusion don't mean you can't have it. You're probably more indicated to have an appropriate removable appliance and clear aligners than you are braces. Those aren't going to help you out.
Thank you. Can expansion cause over-release of the jaw to cause a posterior open bite?
I've never seen that happen. And so the upper development usually allows for some really good occlusion, because any patient that's narrow has a fair chance that they're also then lower retrusion is part of that. In other words, the more narrow the upper arch, the more trapped the lower jaw is. And it tends to come with a deeper bite. So when you're thinking about the predominance of what you're looking at, you're going to see more crowding than spacing cases. Generally, the population is underdeveloped, so we see lots of crowding. So crowding is more common than spacing. In the crowding column, basically you have the most common in the crowding column is going to be a deeper bite. So you got someone who's overclosed. Now, an overclosed bite, any type of retractive technique has a fair chance at opening up the posterior bite, because you end up with anterior prematurity. So the thing you're looking to avoid is retractive or distalization techniques where the upper front teeth come back a little bit. Because if the upper front teeth come back even a little bit, you've got your anterior prematurity thanks to that deep bite going on. Next thing you know, you see an opening. But these appliances, since you're driving with, anytime you're having foundational change, I believe it's Dr. James McNamara, had some really nice research out of the University of Michigan where they showed just transverse expansion alone delivers a little bit of forward movement. So a point travels forward a little bit, even if you're just delivering, wider. Not to mention, if you can recruit some myofunctional therapy, tongue into the palate, that's what drives the whole upper jaw forward in the first place, if you get your tongue where it belongs. So you put the two together, when the maxilla is growing nicely, you get the full shoebox closure. So your mandible can slide into place without having a posterior open bite. So I don't have an example of posterior open bite because I'm really working on, the focus is always maxillary development fully, and then you get your lower jaw to come, forward and close appropriately and get your occlusion without having a posterior open bite.
Can a patient anticipate spaces between the teeth if they don't have crowding but have narrow arches following the use of a removable expander?
The only time I see spaces are examples where the lateral incisors are undersized or the patient comes in missing teeth. And so if you have undersized lateral incisors like we saw in that nice young girl, all of a sudden you're going to get a little space around them, because when you develop the full foundation, the teeth should just connect nicely. The other example where you start to develop some space is where you have missing teeth to start. And so let's say the example will be the 4 bicuspid extraction. If you're missing 4 bicuspids and you're missing your 4 wisdom teeth, well, you're down to 24 teeth out of 32. If you go and start developing, there's a point where you may get some space opening up in the arches, but not a significant amount. So that becomes a whole nother conversation. Do you go about replacing the missing teeth or not? And there are cases where we choose to replace those missing teeth. There are cases where we just develop as much room as we can without replacing those missing teeth. So I would expect only a little bit when the laterals are too small or there are missing teeth. Otherwise, not so much. What you get is the crowding to go away, though.
Absolutely. And last question, is there an age limit?
There really isn't an age limit. You can play with just about any age. You would alter your technique a little bit because with the maturity of the bone comes a change in the technique you would use. I have used these through the 50s. I have not done this in the 60s, 70s, or 80s. I have used clear aligners through the 80s. And I don't have an age limit on clear aligners. Removable, I would probably think about, through the 50s with ease. And in the 60s, 70s, and 80s, I haven't really approached the patients as much, given what we can do with some clear aligners for them and their level of acceptance for an appliance like this.
Okay, last question. How many adult cases have you done? And in your experience, has it resolved upper airway respiratory syndrome and OSA?
Yeah, so the adults are in the hundreds. I treat more children than adults, but I have had, several hundred adults treated. The children and teens is in the thousands now because my orthopedic / orthodontic journey began 17 years ago. This is my 27th year in practice. I spent a decade doing restorative dentistry, implant reconstructive stuff before beginning an orthopedic journey, which, it really began because of looking for an expansive technique. I wanted to do something other than extract. I wanted to develop the jaws, and I started looking for education in that direction. So over the course of time, I don't have an example of a patient that didn't get an improvement. In other words, when you give the tongue more room, good things happen. And so it depends upon how many things they'll let you do, because if the adult will let you do the removable appliance followed by aligners, you're going to do a great job. You get a level of improvement. But if that adult has a tongue tie and they'll go through myofunctional therapy with revision, that'll make a difference. If they have a deviated septum, that'll make a difference. Now, the myofunctional therapy, don't discount that, because there's research in the myofunctional therapy community that shows myofunctional therapy alone can reduce an OSA diagnosis. And that's just, that's breathing exercises. That's physical therapy category, not appliance therapy. So look at the wonderful stuff that myofunctional therapy can do. How about combine it with orthopedic / orthodontic process, myofunctional therapy, and then a little nasal hygiene. So the more you can do, the better will be your outcome. But we have enough success to be confident saying that every patient we treat, regardless of the level they commit to doing, is going to have an improvement because of the technique of going wider and forward. So anything you could do wider and forward makes an improvement. Your patients will be very happy about it.
So I heard you often refer to the technique that you that you've used through the years. And luckily, you've developed a course to teach this technique. So we do actually have our mini residency. We have it for adults and for pediatrics. We do have a couple of spots open this Friday. If anyone's interested, you can reach out to me. I'll give you the contact information shortly. But this is a wonderful program to teach you how to do it. You know, there's so much curiosity and there's so many questions about expanders and how to use them properly, that this is why we created this program, so you can get started. Dr. Miraglia, you just want to share a little bit about the mini residency?
Yeah, so the the idea was that having this nice success is on one level is very rewarding for the patient, for my team, my tiny little community. But if you could do it long enough and make it predictable enough, and then teach other people, well, then you have opportunity for other communities to benefit too. And so there's only so many people I can treat, but if I could teach another general dentist to pick up some orthopedic technique through removable or fixed expanders during the appropriate age times, all of a sudden they could be able to offer it to their population, because I know they're seeing the same patients with the same symptoms. It's everywhere. And so every dental practice has the opportunity to treat these patients differently. And it took me a while to put these pieces together. I spent the better part of 10 years learning from different people and different techniques. And then I figured out, what I liked the most. And I tried to simplify it as much as possible, because just the way I work is the simplest that I could make it to deliver the most significant change was the way I wanted to, practice. And now that I feel really good about it, I'm sharing it. And so we share it, we teach it, and we help to mentor those doctors too.
Absolutely. So thank you for that. I also want to give you some information. We do just start a YouTube channel, Airway Health Solutions. So we have different airway chats. So you can share that with your team members as well. We have hygiene chats, and we will be having treatment coordinator chats as well. Follow me on my expansion blog, rather. I will go through my experience. I do make it very patient friendly on purpose, so you can use this as an educational tool for your patients as well. So visit me there. We have a great event coming up with a collaboration cures through the AAPMD. Please take a look at their website. We'll be doing a bonus track on these removable and fixed expanders. So hopefully we'll see you in November the 12th and the 14th. Check that out. And what else do we have? Oh, here are our upcoming conversations. So we're going to have next week, October 28th, Dr. Ben Miraglia back with the clear aligners as expansion appliances. So we're just going to focus on that topic. So this way we can dive in like we did tonight. On November 4th, I have oral surgeon, Dr. Scott Siegel. He's going to come in and remove some adult case reviews of tongue ties, because a lot of people know about the children, but we're going to focus on the adult segment for our purposes. And then on the 11th of November, we're going to do the fixed airway expansion appliances in children. And then on December 2nd, we're going to have our friend, Dr. Felix Liao, come join us for his new book release. Tell us about that. Licensed to Thrive, a Mouth Owner's GPS to Vibrant Health and Innate Immunity. So good things coming up with Airway Health Solutions. We want to spread and raise an awareness. So thank you for tuning in tonight to help us do that as well. Here's the contact information. We want to thank Ollendorf Appliance Lab. They co-hosted this event with us, with their clients, so thank you. If you reach out and you want the specific appliances that Dr. Miraglia is using, please mention Airway Appliances to our dear friend, Kevin. So I know we're a couple minutes over tonight, but we had a lot of questions. Thank you, Dr. Miraglia. It's always very helpful. I always learn something new every time I speak with you. So we really appreciate your knowledge and sharing this evening. And thank you everyone for tuning in.